Hello everyone, you're watching sqadia.com. So if a patient has come walking in around 18-year-old male and he complains of back pain, would you straight away think of ankylosing spondylitis? I don't think so. Because the signs in this section we'll be going through the signs and symptoms of ankylosing spondylitis, what are the type of x-rays which need to be done, and what are the findings on those x-rays, what is the lab work which proves or which points out that the patient is having ankylosing spondylitis, and what are the differential diagnosis, because every back pain is not ankylosing spondylitis and you should be thinking of some other things as well, and every back pain is not a mechanical back pain as well. So what are the symptoms on presentation? It actually starts insidiously. The patient may be having ankylosing spondylitis for 2-3 years and then this kind of symptoms comes in. Our patient may be having some kind of patient had an infection 3 to 4 weeks, 6 weeks ago, and then suddenly develops these symptoms. Or when you dig out a history, sometimes way back in 2 years ago, there was some kind of a dysentery or a bowel infection. And now the patient is coming with these kind of symptoms. So this is important, that sometimes the onset is not really sure. The patient himself or herself is not really sure that what actually triggered it and when it all really started. Usually it's a teenager, a young adult complaining of backache and stiffness recurring at intervals. Now, it could be that there was some kind of this episode, and that is why I just told you that usually it's not properly treated at times. Most of the time it's treated as mechanical back pain, and painkillers, anti-muscle relaxants, and all these are actually given. And as a result, patient feels comfortable and then carries out his or her routine. But then it actually recurs after some times. So there may be a history of recurring low back pain off and on, especially in a young adult male. Symptoms may worsen in early morning and after inactivity. Actually, this should ring alarm bells, because this kind of symptoms of inactivity and morning stiffness with low back pain, this kind of things just don't happen in normal mechanical back pain. Usually, mechanical back pain is usually a trigger associated with lifting of heavy weight or something like that. But if there is morning stiffness is there with low back pain, you should think of or at least suspect ankylosing spondylitis. Now, it could be rapid pain in the buttocks or the thighs, which usually mimics sciatica. That is one also reason as well that a patient may come to you and complain of classical bilateral sciatica, and sometimes they're treated as such as well. But eventually, once if MRI is not done, we are not really sure that whether it was the disc bulge which was causing those symptoms or it's the basic underlying mechanism is ankylosing spondylitis. Usually mistakenly treated for intervertebral disc prolapse, and it's very common. Why? Because the symptoms actually mimic classical symptoms: low back pain, stiffness, usually radiation. So most of the time it's treated for disc prolapse, but it's actually not the disc which is the problematic area. It's basically fibro-osseous junctions which is the problem. Now this is a cervical spine X-ray lateral view. On the right side you have a normal spine. If you see, it's a curved like this. It's a normal spine with lordotic curve. And if you see it over here, it has actually straightened out. Compared to if you see the intervertebral joints, they are quite straight at least. But the fibro-osseous junctions and the junctions of intervertebral disc, as you can see, there's a collapse, fibrosis, and ossifications as well. And there's increased ossification, which is leading to increased degree of sclerosis as well. Now, anteriorly, you see there is loss of concavity as well, and there's increased straightening, and there's loss of that lordotic cervical spine curvature. And once, now this probably would be after some degree. If we allow it to progress, eventually it will become more hyperkyphotic, leading to drop postures. Because once it has established ankylosing spondylitis, the classical finding is their neck drops and they are unable to see forward. So to see forward, they have to lift up their eyes. So this is a classical symptoms in ankylosing spondylitis, and it happens because of the hyperkyphosis of the cervical spine. Now, gradually, the pain and stiffness becomes continuous, and other symptoms which include are general fatigue. There may be pain and swelling of joints. tenderness and insertion of the Achilles tendon and foot strain and pain, because it's not only the axial joints which are involved, that includes spine, sacroiliac, symphysis pubis, manubrium sterni, costovertebral joints. Sometimes the peripheral joints, once the disease progresses, actually this peripheral joint starts to involve, and there may be constitutional symptoms of general fatigue and pain, swelling of bilateral hip joints, bilateral knee and elbow joints as well. And it's arthritis sometimes mimics like that, but sometimes we have to, when you're examining a patient and taking history, we need to rule it out that whether this knee swelling was was it preceded by some degree of low back pain or anything like that or not. Because if it was straight away a knee pain, then it was either peripheral arthritis or rheumatoid, most likely or osteoarthritis. But if it was preceded by low back pain and stiffness and these morning stiffness and constitutional symptoms, that means it was most likely the ankylosing spondylitis, which has now progressed so much that it's actually involving the peripheral joints as well. Then there is always element of asthenopathy or asthenitis, that is the tendons get inflamed, especially the Achilles tendon. And Achilles tendon's inflammation actually results in, also there is some degree of plantar fasciitis as well, and midfoot and hindfoot pain as well. Now this is the diagram which is actually showing the classical symptoms of asthenopathy and asthenitis as well. There is Achilles tendon which gets inflamed. This and there's a plantar fascia, and this which helps to keep the arches of the foot stable, but that also get inflamed, resulting in basically a flat foot and midfoot inflammation and pain, and some hindfoot pain as well, because the hindfoot and midfoot actually become unstable due to inflammatory joints and inflammatory tendons which are crossing those areas. Occasionally, the disease starts with pain and swelling in the peripheral joints, ankle, and pain and stiffness of the hip. Now, once it has progressed from axial joints, it goes to the peripheral joints, and once it has progressed to peripheral joints, then it results in different other symptoms as well. In women, the axial skeletal disease may remain restricted to sacroiliac joints, making it more diagnosis challenging. What happens is that there's a disease called as sacroiliitis only, that affects only the sacroiliac joint, and then there is sacroiliitis of ankylosing spondylitis as well. That is, in some stages of ankylosing spondylitis, the sacroiliac gets involved, it gets inflamed, and then eventually becomes fibrotic and finally ankyloses. But in sacroiliitis, there's only inflammation of the sacroiliac joint. Sometimes to differentiate between the two, it's really hard, and times you have to be, it's a diagnostic dilemma, whether it's ankylosing spondylitis or it's sacroiliitis. Now, this is early on, only slight flattening of the lower back and limitation of extension in the lumbar spine is present. The first to go is the extension, that a patient is not able to bend backwards. And why it is not able to bend backwards? Because the lordosis, normal lordotic curvature of the lumbar spine is actually lost, and lumbar spine is straightened out. Then is hypolordotic posture, that from there actually it gets to hyperkyphotic, that the straightening and leading to increased kyphosis. Now there is a diffuse tenderness of spine and sacroiliac joint. On examination, usually the lumbosacral junction and the sacroiliac junction is actually where the main problem is, and that is why sometimes it's highly tender when you palpate these areas. There is swelling and tenderness of single large joint as well. Now this is important. If that is only, suppose right-sided hip joint or right-sided knee joint is involved as well, then you need to differentiate on the history as well as the examination, that was this preceded by some degree of low back pain, stiffness as well or not, or it is actually a peripheral arthritis to start with. Now coming to the typical posture in established cases, there is a loss of lumbar lordosis. As a result, patient is bending forward, increased thoracic kyphosis and forward thrust of the neck. Upright posture and balance are maintained by standing with the hips and knees slightly flexed. Why? Otherwise, they would simply fall down. Because if you are too much stooped forward, there is always a chance that you may fall forward. So to compensate for that, because now the lordotic spine of the lumbar normal curvature, which is lordotic, or the normal lumbar curvature is actually lost. As a result, patient is stooping forward. To compensate that, so he or she does not falls forward, they have to actually bend their knees and hips, so that actually it's called center of axis of the body actually remains behind the pelvis rather than moving forward to the pelvis. In the late cases, they may become fixed deformities of spine and other joints. Once these joints become ankylosed, for example, sacroiliac joint or hip joint, then there may be no movement at all, and there may be fixed deformities, fixed flexion contractures of the hip and knee may be present. Now, in case this is on the right side, you can appreciate there's two diagrams. One is the patient, actually a normal patient is performing a wall test. If a patient who does not have ankylosing spondylitis is asked to stand and with his or her back towards the wall, all those areas, for example, back of the occiput, the two scapulae and the hip will all touch the area. For this and scapulae and the hip would touch the back with their heels touching the wall at this time. But in case of a person who is having ankylosing spondylitis, because of normal curvatures are lost, as you can appreciate, this is the normal curvature, lordotic curvature of the lumbosacral spine. It has actually decreased, so there is an increased kyphosis and straightening of lumbosacral spine. So if their heels are touching the wall, usually their hips and occiput and scapula are not touching the wall. Only this hump or the slouching forward results in some part of the hump only touching the wall, which is usually actually the thoracic spine level. Why? Because it touches, because the thoracic spine has actually gone into hyperkyphosis. Spinal movements are diminished in all directions. There is decreased flexion, extension, lateral bending, all in all planes. There is loss of extension. It is most severe disability. Coming to the wall test, I've just explained that patient is asked to stand with his back to the wall with heels, buttocks, and scapula and occiput should all be able to touch the wall simultaneously. If the extension is seriously diminished, the patient will find this impossible. Marked loss of cervical extension may restrict the line of vision to a few paces. What results is, as the neck falls forward, the patient is not able to maintain his or her gaze. So to actually look forward, they have to look like this because their neck is actually going slouching forward at that times. Then, as we know that the costovertebral joints are also involved, so we will definitely measure the chest expansion. There are multiple methods of measuring the chest expansion. One way is to simply first use a tape and measure how much centimeter of expansion has taken place. The other is actually this is the mechanism, which is by standing behind the patient. So another way out is that patient is lying supine and you're examining the patient from the front, and the chest expansion can be measured from the front as well. And the displacement of the finger is actually measured, and that is how it is taken up. In young men, it's often markedly decreased. Usually, normally it's not. In old, the chest expansion, which should at least be 7 centimeters in the people, they may have pulmonary disease, and usually they may be markedly diminished. Sometimes the patient may be having some degree of pulmonary fibrosis or some like COPD, which is a disease of old age. In these diseases, there is always reduced chest expansion at times. So costovertebral arthritis cannot be predicted accurately by chest expansion alone. Especially we have to take care for a patient who is old age and have some kind of a respiratory problem. Then chest expansion should not be taken as involvement of costovertebral joints. Now this is a diagram, this is a normal posture. Neck is up straight, but as the neck has gone into kyphosis, thoracic spine is actually bending forward, so they cannot look up. Now this is another patient who has ankylosing spondylitis. Can you appreciate how much bending forward of the neck has taken place, so that he can only see his feet and maybe few paces ahead, but to look up it becomes problematic. So they cannot really put the removal because their neck is too down, so they cannot properly look in front. But that is the same patient after surgery, and now you can appreciate that the curvature of the spine has been reduced and restored, and the patient can see now for in front. What exactly? Now, coming to the peripheral joint in ankylosing spondylitis, they may also get involved, although initially it's the axial joints, but then it's the knee, the hip, and other joints which may get involved as well. Peripheral joints, usually shoulders, hips, and knees, are involved in over a third of the patients. Features on inflammatory arthritis like swelling, tenderness, effusion, or loss of mobility may all be present, which are mainly of arthritis. Like in rheumatoid or osteoarthritis, usually these symptoms are all present in the peripheral joints. Now, what we need to consider when the patient is coming with a history of a back pain, then what are the x-rays which need to be done? The most common x-ray is x-ray lumbosacral spine. It's AP and lateral view, which would show the lumbosacral spine, the sacroiliac joints, and it's actually the AP and lateral view would show how this is an AP view which is showing sacroiliac joints, although there very much some degree of ankylosis is present over here, but not all, although there is still reduced joint space. Then other include the X-ray pelvis, AP view. This is to see because the both hip joints sometimes may be involved as well. So what is the status of the hip joints and other hip bones that needs to be considered as well. MRI with or without contrast is sometimes needed, because MRI, especially when we are dealing with spinal deformity, not only to rule out other causes of like prolapse, disc, and other. MRI is probably more diagnostic because it's exactly show where the inflammation is, where the ossification has taken place, and where how much joint has actually enclosed and degraded itself. Coming to the lab workup, although they are not pathognomic for ankylosing spondylitis, probably in other inflammatory arthritis as well, you will see a raised ESR and CRP count because there is some degree of inflammation as well. A rheumatoid factor may be negative; it's only positive in RA times and some other seronegative as well. But HLA-B27 is most pathognomic for ankylosing spondylitis. If he or she is HLA-B27 positive, then most likely with these kind of symptoms, the patient is having ankylosing spondylitis. Now, if you see, this is an X-ray hip pelvis and hip joint, which is showing over here. It's very much cardinal sign which appear early is the erosion and fuzziness of the sacroiliac joint. If you see, this is the right side of the sacroiliac joint, this is the left. There is marked reduced joint space as compared to the right side. If this come over here, well, there's some degree of joint space over here, but I cannot appreciate any joint space above this level. Then periarticular sclerosis and iliac side of the joint, and finally bony ankylosis. Earliest vertebral change is the flattening of the normal anterior concavity of the vertebral body, that is squaring of the vertebra. Ossifications of the ligaments around the intervertebral disc produces delicate bridges between the adjacent vertebra. For example, now these two are the patients of ankylosing spondylitis, and this is the normal axial lumbosacral spine. Now, this initially, if this patient may only have some degree of straightening of spine. If you see clearly, there is no reduced marked joint space, there is no increased ossification, and fibrosis complex may be normal at this level. That is why there is always a problem in diagnosis. Sometimes even the X-rays early on may appear normal. So at this stage, it's very difficult to say the patient may be having ankylosing spondylitis. But once it progresses and eventually it reaches at this stage, there is some degree of squaring of the vertebra, but now the squaring has actually completed. There's increased fibrosis, ossification of the intervertebral discs as compared to the normal X-ray. This is also showing X-ray spine. If you see it over here, on AP view, there is marked reduced joint space. I cannot appreciate any intervertebral disc space over here. Similarly, anteriorly, if you see increased sclerosis of element is there, increased squaring of the vertebra is there, although fibroosseous sclerosis is also present. What would you be thinking when your patient would present with these kind of symptoms? The first and most commonly which is thought of is the mechanical disorders. For example, muscular strain, fascicular dysfunction, spondylolisthesis, that is slippage of the vertebra, and diffuse idiopathic hyperostosis. Other things which you may come to your mind, because sometimes the peripheral joints are always involved as well. Then these include Reed's disease, psoriatic arthritis, ulcerative colitis, Crohn's disease, Whipple's disease, and Paget syndrome. Thank you very much. Keep watching sqadia.com.